Hi, and welcome to Ethics and Consumer-Driven Treatment, brought to you by allceus.com. Part of consumer-driven treatment is being aware of what your consumers' needs are. So we're going to start with Maslow's hierarchy. Most of us probably learned about Maslow's hierarchy in Psychology 101, but just to review, it's a pyramid. The bottom part of the pyramid, or the foundation, is safety and biological needs. So your biological needs are food, medical, shelter, all those real basic stuff, followed by safety. And a lot of people think of safety as being safe from other people. Of course, we don't want our clients to be in relationships that are abusive. We don't want them to be living in unsafe environments. But for many of our clients, more problematic than external safety is safety inside their own heads, because they have those negative tapes that keep playing over and over and over again, those negative thought patterns that are still sort of beating them up. So one of the first things that I like to focus on with my patients is trying to create an environment of safety in their own heads as well as around them, and making sure they're getting all those basic needs met. Let's rule out all the physiological causes of their mood issues. Let's rule out chronic pain, or if there is chronic pain, how do we deal with it? Let's look at side effects of medications, or are they even taking their medications? If they're not, is it because they don't want to, because of side effects, because they can't afford to? What could help them be more med compliant? How are they eating? Now, most of us are not nutritionists, but we can make a referral to a nutritionist if needed. Oftentimes, it's more basic than that. Clients just don't have food. They don't have access to food. So we need to make sure they understand basically the different food groups and how to tap into social services to get food so they can meet their nutritional needs. We need to make sure that they've got health. If they're sick all the time, if they're dealing with a chronic illness, we need to help them understand how that factors in to any chronic pain, sleeping problems, mood problems, relationship stressors, etc., because it all feeds into one another. Once we get past that and they can be safe in their own head, then we can start working on relationships, again, with themselves, so they learn to appreciate themselves and establish healthy relationships with other people that constitute love and belonging. Develop those sane, sober social support systems. Once you have those, then you can start working towards self-esteem. For many of our clients, we will see them long enough to help them establish safety in their own heads, and then they may drop out of treatment for a while to come back later and start working on some of the other issues. But that's okay. A little bit of forward movement is still a little bit of forward movement. We also need to understand how mental health, medical issues, and addictions all interact. Depression. If you have depression, let's think about the symptoms. Not finding pleasure in just about anything most of the time, most days of the week. Sleep disturbances, eating disturbances, a sense of hopelessness and helplessness, fatigue, agitation. Okay, so our client meets some of those criteria. Sometimes people have anxiety first. That agitation and worry and anxiety is so strong that they get exhausted. So they're anxious, but they're also depressed at the same time. Look for that. See if there's some anxiety that's keeping them revved up that is undermining or underscoring their hopelessness and helplessness. And then look at addictions. Now we know that oftentimes addictions are used to stop emotional or physical pain or both. So if somebody is anxious all the time and they can't sleep and they're restless and they're agitated, at a certain point they need a break. And some people develop addictions. Unfortunately, addictions usually make all the rest of it worse. So you can see how all these things might kind of fold in on each other. Talk with your client. Have your client identify not what diagnoses, but what symptoms they are most motivated to work on right now. What is it that if you could find some relief in the next week, you would want to focus on? We also need to look at how bipolar disorder and addictions play into one another. How do people behave during manic episodes with regard to their addiction and with regard to their health maintenance behaviors? How do people behave during their depressive episodes? Some people, when they're depressed, withdraw from others, but they don't use as much. It's when they're in their manic phase that they are binging on different drugs, especially stimulants. Some people are the opposite. During their manic phase, they engage with lots of other risky behaviors, but the addiction is the least of what they're doing. Some people, it doesn't matter if they're depressed or they're manic. It's just a different mode of addiction or a different intensity of addiction. Understanding how that looks for each patient and what has worked to mitigate it in the past is going to be important to developing consumer-driven treatment, which is different from just treatment because we're looking at the individual needs of the consumer. And we're realizing, finally, that no two people are alike. So in order to provide the highest quality treatment, beneficence, fidelity, we need to understand the person as a person, not just an individual or a human being with a diagnosis. They're an individual with individual needs, individual preferences, individual strengths. And therein is the key or the crux of this presentation. Ethical treatment is that treatment that looks at the person as an individual person with unique strengths, needs, attitudes, preferences, and goals. Individualized treatment also has to address issues for mental retardation, autism, fetal alcohol spectrum disorders, learning disabilities. We need to individualize treatment by type of disability. Most of our patients don't come in and just have one real simple diagnosis here. They may have a mood disorder, but they also may have autism, and they may have some physical issues going on and a dysfunctional support system. So they've got a lot of stuff that's working together to create this storm for them. And we have to help them figure out how to navigate. We need to look at co-occurring disorders. What's going on with that patient right now? What are they motivated to work on right now? Identify their needs and preferences and be sensitive to their culture and their ethnicity. What do they value? What do they prize? What is their end goal? Not yours, theirs. What's their end goal? What do they see as the best resolution? There's been more than one occasion where a client of mine has had the best resolution of getting back in contact with their family and going back to work at the family business. The family is still steeped in addiction and dysfunction. However, this person's goal and belief was that was where they were supposed to be. So instead of saying, no, you're wrong about what's right for you, we said, okay, here are the problems that you're going to have to address if this is the system that you're going back into. So let's make a plan. So individualized treatment means making sure the client is informed about all possibilities, but then letting him or her choose his or her destination and helping him or her get to that destination in a meaningful way. And what are they motivated to work on? If they're coming to you, and I've used this example before, when I first started my career, I worked in felony drug offender probation office. provided their drug treatment. Everybody who came to see me had an assessment done and then had treatment for 10 to 12 weeks. Okay, kind of a no-brainer. But that's also not consumer-driven treatment. That's forcing somebody into something. It's kind of like detention. So what I would do is I would talk with each patient and say, all right, you're stuck with me for the next 10 to 12 weeks. So what is it that you can get out of this? Is there anything I can help you with? What are you motivated to work on? If their main goal was to get off probation, then that's what we would work on together. Now, it just so happens they'd have to stay clean for 10 to 12 weeks in order to get off probation, which was my goal. But we were focusing on what they wanted. Get off probation, get a different job, work on their relationship. There were a bunch of different, what we used to refer to as Axis 4 things, psychosocial variables that most people wanted to work on. And that is where we focused. I think everybody that came through those groups, as I recall, was in the pre-contemplation stage of change. There may have been a couple in contemplation here and there. It was a long time ago. But in large part, we weren't really hitting on addiction because most of the people that were in there, if not all of them, flat told me, I don't have a problem with addiction. I have a problem with getting caught. Okay, well then let's work on that. So we focus on where their motivation is instead of trying to break through resistance. Consumer-driven treatment involves enhancing motivation in the areas that they're willing to work on. So John comes in and he identifies these 3 symptoms that he really wants to work on in the next 30 days. So you develop a plan with John and we talk about motivation emotionally. Let's look at the benefits to change. Let's look at the drawbacks to change. What are the emotional benefits to staying the same? And what are the emotional drawbacks to staying the same? You go through the same thing for cognitive. Cognitively, what are the benefits? Logically, what are the reasons you might want to stay the same or you might want to change? And what are the drawbacks to staying the same versus change? You want to do decisional balance exercises in all 4 areas for each problem or identified goal. You enhance motivation that way. Another way you can enhance motivation is to say, okay, on a scale of 1 to 10, 1 being you don't want to change at all, 10 being you're just chomping at the bit to change. Where are you at? And they'll say a certain number. And you say, you're there. I wonder why you're not, and choose a number lower. So if they say they're at a 6, say, why aren't you at a 3 on this? And they'll tell you all the reasons that they're more committed to change than a 3. And you go, oh, really? You're that committed to change, huh? So it's sort of counterintuitive. You want to shoot low and say, tell me why you are more motivated than this down here. And then they start listing all the reasons. Then we move on to solutions. Okay, they're motivated to change now. They want to do it, but how? Start by asking them what has worked in the past. They are not doing anything except for like breathing all the time. So when they're not doing whatever it is, when they're not depressed, when they're not anxious, when they're not using, what's different? What are they doing? They're sleeping, they're exercising, they're with a family member, they're walking their dog, they're watching TV. What are they doing? Okay, we're going to do more of that. That's where you want to start. Identify what has worked in the past to help deal with depression, anxiety, whatever the problem is. Do more of that. And then you want to look at those situations again where that problem didn't exist. When you weren't depressed, anxious, using, etc. What was different? We want to try to recreate some of the good parts of that situation. Those are tools the client already has in their toolbox. We're not reinventing the wheel. We're not trying to teach them a brand new skill. We're helping them pick up stuff that they had before and go, oh, I remember how to use this. And then strengths-based. So we figure out what they're motivated to work on. We identify the solutions that have worked for them in the past and try to enhance them and increase them. And then we increase something that exists because it's easier than adding something that does not. We use the client's current strengths. What's worked? Let's keep doing that. Teaching them a brand new skill. You're not going to wake up in the morning and go, oh, there's this brand new skill and I'm an expert at it. When you're in crisis, you fall back to the things that you know work. So if you can start with something that you know has worked sometimes in the past, it's easier to integrate that into your repertoire than something that's totally new. Strengths-based, solution-focused, and motivation. Medical necessity, consumer-driven treatment. Okay, we're talking about the consumer. We're looking at their individual differences, assessing their strengths, their needs, and their preferences. Well, medical necessity is a need. Use evidence-based practices that are effective. The National Registry of Evidence-Based Practices, takes a lot to remember that acronym, has a list of current evidence-based practices that are in use. Start with those. Get training on those. Empower clients to learn to solve their own problems, not to be dependent on you for answers. Use some Socratic reasoning. If a client asks you, well, doc, what should I do in this situation? Ask them, well, have you ever encountered a situation like this before? If they say yes, say, what'd you do? How'd it work out? Could you do that again this time, or what would you do differently this time? You're helping them learn to solve their own problems. You're not giving them the answers about what they should or should not do. Because that just always comes back to bite you in the butt. If you tell them what they should do and it works out, then it fosters dependence. If you tell them what they should do and it doesn't work out, then they blame you for things falling to crap. So try to have them solve their own problems. Don't keep people on your caseload just because they're good clients or because their insurance pays well. If they don't need that level of care, don't keep them at that level of care. If they are substance abuse clients and you're a mental health facility, don't bring them on just because, yeah, well, they probably have some co-occurring mental health thing going on. If all your groups are substance abuse, primarily focused, you treat co-occurring, but you really talk a lot about relapse and 12 steps and addictive type behaviors, then don't take somebody who is purely with a mental health diagnosis. I've had situations where supervisors have tried to get me to admit people to a program in which they weren't appropriate because there were openings in that program, and it's not in the best interest of the client. It is not ethical to stick a client in and say, oh, we're co-occurring, just because every once in a while you talk about depression or anxiety. If you're not actively treating that in a way that's unique to the client, to the disorder, and to the situation, then you're providing unethical treatment. Boundaries, burnout, and self-care. Don't let your personal life bleed into your professional. If a client comes in and goes, oh, how are you doing today, doc? And you go, oh, let me tell you, these children of mine, no, that's not okay. Maintain awareness of your biases and maintain awareness of your stuff. When you're in session with the client, keep your stuff in this little box over here and your biases in this other little box over here, and get consultation or therapy as necessary. Self-help groups. Don't sponsor your own clients. Again, it creates dependency, it creates a dual relationship. There's all kinds of ugly stuff that can come out of sponsoring a client. What if the client reaches a level where they don't need to be in therapy anymore, but you're still their sponsor? Then are you providing therapy as the sponsor? What if while they're still in therapy with you, they're wanting things that seem more like therapy during your sponsorship sessions? Do you charge them for those? How does that work? See, it gets really icky. Really, really icky. So don't sponsor your clients. Try not to even be in the same home group or meetings with your clients if at all possible, because it creates this weird dynamic. If you can't avoid being in the same large groups, you need to address that with your clients early on in treatment. Home groups are very small, very intimate discussions. Really strongly advise not being in the same home group as your clients. If you have concerns about boundaries, seek consultation. If you are an alcohol and drug counselor, addictions counselor, certified addictions professional, whatever your state calls it, you want to get consultation from somebody who has a substance abuse background. If you are in recovery, but you're seeing the patient for a mental health issue, and you end up at the same meeting, again, you want to get some consultation, preferably from somebody who works with co-occurring disorders, but who has an awareness of what the 12-step community and culture is all about. Remember, if you would be embarrassed if somebody found out, don't do it. That means you're violating some boundary somewhere. Remember that transference is a therapeutic issue, and it can occur in the outside world as well. You can see the person that sits across from you at work may remind you of your favorite teacher from elementary school. So you automatically have these positive interpretations of everything he or she does. It can work to the negative, but we're staying positive today. I'm kind of a glass half full kind of gal today. Remember that transference occurs anywhere, and you need to keep it in check. It also occurs in the therapy sessions. Clients can have a transference reaction to you. They may perceive you as a mother figure, as the best friend that stole their boyfriend. I guess that's getting negative, but or their best friend from childhood, and they may feel automatically comfortable. They may also have different interpretations about things that you say if they're perceiving you in a light other than this brand new person that they've met that's a therapist. So do be aware of any transference reactions that a patient has toward you, as well as countertransference. Also, any anger or dismay, or even happiness, but we'll focus on anger, dismay, irritation that a client has toward you, isn't always the result of transference. Sometimes it's because you screwed up, or they didn't like what you had to say. And that's not necessarily transference. It's a therapeutic issue, but it's not necessarily transference. So don't explain away every bad or negative statement or communication as transference. Look at it, examine it with the client, and try to figure out what's going on. Remember that when you feel frustrated, irritable, or hopeless, you may be perceiving the client's feelings. When I work with clients who have borderline personality disorder, I can tell you there's a lot of times I feel very frustrated, helpless, and exhausted. And we talk about that. There are times when we're in a discussion and it feels very circular, like we're getting nowhere. We'll talk about that. How it feels, why it feels that way, and what the possible options are, because my guess is they're feeling the same way. I mean, helpless and exhausted, if the patient feels that way and they're coming to you and saying, I'm feeling helpless and exhausted, and you start feeling helpless and exhausted, then it compounds there. So it's a vicious cycle. So talk about it, saying, you know, I get the sense that we're stuck here. Take those feelings and use them to inform your conversations. Gifts and bartering. At the beginning of therapy, when they sign their HIPAA stuff and everything else, provide written policies to clients regarding gifts, payment plans, and bartering. Generally, gifts over $5 are a bad idea. Every gift needs to be taken in consideration of the client's culture. However, if you let them know ahead of time that you're not able to accept gifts over $5 or not able to accept gifts at all, then they don't take it as personally. You need to consider it in terms of what's going on. If you're seeing children and a child makes you a card or makes you something in art class, is it okay to take that? What are the consequences of you rejecting that gift? Payment plans. Have the same payment plan for everybody. Don't just kind of wing it and go, oh, well, your insurance is going to pay this much, so we won't worry about your co-insurance. Not okay. Have it written down. Have your sliding scale. If you've got a sliding scale, have your policies and make it consistent for everybody. One of the biggest things that we see correlated with lawsuits against therapists is that the patients have often gotten behind in their payments and they owe the therapist a lot of money, so now they're trying to say that the therapist was not behaving ethically or didn't provide effective treatment. Don't let patients get behind. Make sure your payment plans are consistent. Make sure you document everything you do. Bartering. Bartering is a sticky wicket. I know it happens in a lot of places. Be aware that a client's perception of how much his or her services or goods are worth may be different than what your perception is, and vice versa. If a client comes in to see you and you're on a bartering agreement and they're giving you 3 dozen eggs, I don't know, we'll just go with something. They're giving you 3 dozen eggs. There's a concrete value assigned to that. So when you're on your game, the client may feel like you're worth 3 dozen eggs. But when you're off your game, the client may be like, that really wasn't worth 3 dozen eggs. I'll give you 1.5 dozen. It's an example. Obviously, you're not going to do 3 dozen eggs. But you get to understand that regardless of the service, there could be misunderstandings or beliefs that one service is more valuable than the other on any given day. So bartering tends to be a problem and creates a lot of room for misunderstandings and ethical conflicts. Use consistent policies for admission, for discharge, for discipline, for payment, gifts, bartering, boundaries, consistency. If you show that you've been doing this with every patient, man, woman, 20-year-old, 60-year-old, within reason. Obviously, we're individualizing treatment, so there's going to be some difference. But if you're only hugging your attractive 20-year-old clients and nobody else, that's not going to reflect really well. If you show that you hug most of your clients, you could argue whether that's ethical or not, but at least you're consistent. So use consistent policies. Try to use policies that are consistent not only in your practice, but throughout the profession. If nobody else in your circle of colleagues hugs their patients, probably a reason for that. Let's not hug our patients. If other people do, then understand what the limits and boundaries are and how those communications kind of play out. Again, remember, bartering is always discouraged. It happens sometimes. It is something you definitely want to carefully go over and create a contract with the client, have it reviewed, ideally by an attorney. If it starts to go bad, don't try to resolve it yourself. The recommendation is to have a third-party impartial mediator try to resolve the issue. So individualized treatment, learning styles. Not every client is an auditory client. So sitting there talking is not going to do a whole lot if they are a visual client. They learn better by reading. Kinesthetic clients do better by working with the information. So if you ask the client to apply principles, that will help them. If you ask them to, if you're in group and you ask them to teach a particular topic, that will help them. Visual learners do best if they can read. PowerPoints, handouts, anything that can support what they're hearing. The more modes of information communication you use, the stronger the memory connections. And it's important to remember that some people are active learners. That means they learn as they go. And some people are reflective. And it'll be almost like they're not paying attention, and then you take a break, and you come back, and they've assimilated everything, and they're on. So some people need breaks. Take frequent breaks during group, even with adults. Every 15 to 20 minutes is good to at least take a, okay, let's stop for a second and do this worksheet, or think about what we've talked about. If every 20 minutes you let people get up and go to the bathroom, you'd never get anything done. But you do need to take a little time out, if you will, for people to sort of meditate on what they've just heard and figure out if they have any questions and how it applies to them. Temperament is also huge. People who are extroverts are way more attuned to what's going on around them instead of what's going on inside them. So we need to help those people focus on them instead of everybody else in the room. Introverts tend to be more aware of what's going on inside them and less aware of how they impact others and what's going on around them. So again, we need to just help increase their awareness. Introverts need downtime every day. So if you're in a residential facility, make sure your introverts have time where they can go sit out under a tree, sit on a picnic bench, have some quiet time to just regroup and get grounded. Extroverts, on the other hand, regroup and get grounded as they talk, and they draw energy from other people. So they need a time where they can just kind of sit down and chew the fat, so to speak. Sensing, those are your fact and your detail-oriented people. They can get too caught up in the minutia and miss the big picture. Intuitive people are your broad strokes. We focus on the big picture. Getting this grant, recovery, improved quality of life. But we may miss some of the little details in there, like how to do it. That's a little bit of an exaggeration, but intuitive people tend to focus more on the big picture, so we need to help them focus on the small details. Okay, you want to attend AA. That's great. That's a broad stroke. What groups are you going to go to? How are you going to get there? And who's going to watch your kids? Oh, those are details. Details, details, details. Thinking people, which I don't really like this one because people who are feelers do think. But in this mode, thinking people tend to focus on words like justice and fairness and see things more in terms of black and white. Feeling people talk with feeling words. They talk about how angry or upset or devastated or elated they were. They think of things in terms of fairness and compassion. So they see the grays. Neither one's right or wrong. We just need to try to bring both of them more towards the middle, or enable both of them to think more towards the middle when they need to. Judging versus perceiving. Judgers, I am a pegged out J. I love my structure. I love my calendars down to the 15-minute increments. I don't like surprises. I like to know exactly what's coming up. I have routines. It makes me happy. I'm calm. Perceivers get really bored if life is that structured. They want to be impulsive. They don't want to be pinned down to going to this one meeting at this one time all the time. They want to have variety. So when we're talking, for example, relapse prevention plans, the judgers over here, they know what meeting they're going to go to, what time, at what location, and maybe even who's going to be speaking. The perceivers, they're going to be more like, okay, after work, I need to go to a meeting. And they'll figure it out when they get there, which meeting they're going to go to. Talk about something else, like exercise. Judgers, I'm the worst about this. I will get in my head that I am going to do stadiums, or I'm going to do spin, or I'm going to do step aerobics, or whatever it is. And if for some reason I can't do that, I have a really hard time wrapping my head around doing some other form of exercise because I was jazzed to do whatever it was. Perceivers, they're like, I need to exercise at some point today. They look outside when the sun's shining, the wind's down a little bit, looks good, then they figure out what they're going to do to work out. So there's a general list for the perceivers, a very structured list for the judgers. When we're talking about relapse prevention plans, whether that's addiction relapse or mental health, it's the same concept. People who are trying to develop their strengths so they can deal with life on life's terms more effectively need to pay attention to their personal preferences. Do they like structure? If not, is their current environment too structured? How can you change that? How can they work within the confines of their current situation? It's important that people realize not everybody's meant to do everything the same way. I am not meant to be a salesperson. I don't do sales well. I have a friend who is the sales guru. Kim can close any sale. She can captivate any audience. And that is fabulous. I will never be like her. It's just not in my temperament. It's not who I am. There are people who love to do computer programming, which is very detail-oriented. I'm a broad stroke. I could not write 10,000 lines of code and maintain my sanity. That's the way I'm programmed. People need to recognize and relish their own unique strengths and what those strengths contribute, and figure out how to tailor our general program, whatever that is, to meet their personal needs. Then they need to learn how to do that on the outside. How can they make their work environment more accurately fit their personal temperament and needs? Do they need more structure, less structure? Do they need more quiet time? Do they need more interaction with other people? Is it possible to do that in that particular environment? How can they get their extroverted needs met? How can they deal with things in a way that's meaningful to them? There's a book, it's called Please Understand Me, and it was written by David Kiersey. Strongly recommend that you check that one out. There's also a book, and I cannot remember the author's name right now. Bad me. One of my favorite books, it's called Effective Teaching, Effective Learning, and it uses temperament and talks about how to use temperament in the classroom. But this can be extrapolated to using people's temperaments or understanding how people's temperaments play out in therapy, individual therapy and group therapy, and how two people of different temperaments may interact differently. Two great reads, Effective Teaching, Effective Learning, and Please Understand Me. Areas of practice. Only practice in areas where you've been trained. If you're not trained in play therapy, don't do it. If you're not trained in EMDR, don't do it. If a client has multiple disorders, addictions, mental health, physical, only address those which you're trained for and consult on the rest. If you are an LPC, you're not going to be prescribing meds. You're going to consult with a psychiatrist. If the client has chronic pain issues, most of us are not trained as physical therapists, so you're going to consult with their physical therapist or their pain doc in order to make a comprehensive integrated treatment plan. Use evidence-based practices. You can find them at the National Registry of Evidence-Based Practices, SAMHSA, or CSAP websites. In small towns, be aware of confidentiality issues. If there's only one bank in your town and you take a check to that bank from John Smith, the teller may know John Smith and may know you're a therapist, and then they're like, I wonder what John Smith's in therapy for. Credit card payments. American Express does not need to know that John Smith went to see you for therapy. Have your billing name be something that is somewhat confidential. You know, Snipes Consulting or ABC Wellness. Something that doesn't say ABC Substance Abuse Treatment. John doesn't want that on his credit card statement. Amex doesn't need to know about it, and the IRS probably doesn't need to know about it. So try to respect confidentiality in places where it might inadvertently show up. Choose your location carefully. You don't want to have an office with a big picture window to your waiting room on Main Street in downtown of whatever town you're in, because then anybody who walks by can look in the picture window and see who's sitting in there. If you can, have a back door that patients can go out so they don't have to see who's in the waiting room, and the people in the waiting room don't have to see who is in the therapy room. Prepare for chance encounters. No matter how small or how big your city, you're going to run into your patients at some point or another. Talk with them at the beginning of treatment about how you're going to handle that. If you see them in the grocery store, you're not going to walk up to them and go, "Hi, Sam." If they choose to approach you, that is their prerogative. But you are going to go on about your business in order to preserve their confidentiality. That way they understand you're not ignoring them or thinking bad of them or being mean to them. You are respecting their confidentiality. If you have to engage in a dual relationship, which happens more often in small towns than in large ones, make sure there is a written acknowledgement between you and the client. Receive regular supervision concerning the dual relationship to make sure that the boundaries are staying nice and clean. And have a sort of drop back and punt plan in the event that the dual relationship becomes problematic. You don't want to reach that point where it's a problem and go, "Oh crap, I don't know what to do." Have a plan. Have a plan that you've worked out with your client ahead of time. Okay, now we've talked about consumer-driven treatment in terms of strengths, identifying the things that they already have that are working for them or have worked in the past. Their needs in terms of providing services that meet their learning style and their temperament, and their attitudes, the cultural variables, what they value, what works for them. Now we're going to talk some more about preferences. Some people like individual counseling, some people prefer group, some people, because of various constraints, maybe they travel all the time or they don't have the ability to get to and from your office for one reason or another, will want e-therapy. Well, that's wonderful. There are certain things that we need to consider. Number one, if you're not comfortable with e-therapy, don't do it. Make sure that you have everything set up so you are HIPAA and high-tech compliant. That includes having a minimum of 128-bit encryption, verifying your patient's identity, verifying their age whenever you do your initial assessment. Now with these, as I've said in my other presentations, you really want to work with patients to have them use video methods of e-therapy. That way you can still see the nonverbals and you lose as little as possible without having them right there in front of you in your office. Also remind them to clear their cache. When they're finished with their e-therapy session, make sure that they clear the cache on their computer just to be on the safe side. Know what diagnoses you're comfortable treating and that your professional association believes are ethical to be treated via e-therapy. Some diagnoses, some issues, you really want to see the person face-to-face in your office. So you can take blood pressure, do urine samples, whatever the case may be. Some things you can handle via telemedicine. Know what diagnoses you're comfortable treating, though. If you're working with people in different states, currently the law says you need to be licensed in the state in which you practice. So if your body is in Florida, you need to be licensed in Florida. But if your client is in Texas, you need to make sure that you know the local number for the authorities to do well-being checks. If you need to initiate a suicide watch, if you need to refer them out to a local counselor, you need to know who in their area is available that might be able to see them. So it's a good idea, as soon as you take on a client in a different locale, to reach out to some local therapists and see if any of them would be willing to be your backup if the client decompensates or decides they want to see a face-to-face therapist. Make sure you have talked with your client ahead of time about what's going to happen in the event you believe there is an imminent danger to the client or someone else. Have a written plan the client signs that acknowledges what you're going to do in the event that you lose internet connection or you don't have internet connection to begin with at the beginning of the session. How are you going to contact them? How are you going to let them know how to proceed? It almost always happens, it seems, that it's not during a time when you're just wrapping up, but when the patient is right at a crucial point and the internet goes kaplooey, or your transmission freezes. That's not helpful. It is useful to make sure that you've got a good, strong cable internet connection, something higher than DSL. And you need to make sure that the connection you have, the verbals, what's being said, and the nonverbals are in sync. Because if there's a delay, then you may get really wrong interpretations about what's going on. Additionally, if the patient is talking with you about domestic violence issues, be aware that the perpetrator could be in the room, the perpetrator could come home, or the perpetrator could get on the computer to look and see what the victim's been doing. So it's important to use additional safety protocols. Better to not do e-therapy with victims of domestic violence that are still in that violent relationship. You want to make sure they get to a safe situation or a safe place before they start doing that. In summary, we need to be aware of a client's needs. We need to be aware of all the ways we could incidentally breach confidentiality and prevent those. We need to remember to regularly consult with colleagues about ways to treat, about certain clients that we have. Even if we think things are going well, run it by a colleague and say, is there anything you do differently? We need to be constantly aware of boundaries, especially as they relate to dual relationships and accepting gifts or bartering. And if you're going to do e-therapy, which is sometimes in the best interest of the client, it's the only way that client is going to be able to access services, you need to make sure that you're competent and that your system is set up in a way that is compliant with HIPAA and high tech. That ends our discussion of ethics and consumer-driven treatment. Thank you and have a wonderful afternoon.